Good afternoon, sir.
Thank you.
Sir, can we start now?
Yep, Ken. Can you hear me? Clear?
Yes, yes, sir.
All right.
Just to give brief little bit. Uh, Good afternoon to everybody. Our next speaker, all of you know that Professor Dr. Hari Krishna, sir. He is giving talk on topical oxygen therapy in chronic wound management. And as all of us know, that he is the president of Malaysian Biotherapy Society, founding president Malaysian Society of Wound Care Professionals, chairman of Pressure Injury Prevention Committee, Hospital Kuala Lumpur, national advisor to Primary Health Ministry of Malaysia, vice director of Asian Academy of Wound Technology, vice president of Asia Pacific Association on Diabetic Limb Problems, vice president of Asian Wound Care Association, faculty member of National Diabetic Institute and chairman of DCOM, member of National Technical Committee on Wound Care, Ministry of Health, and head training committee, Ministry of Health, member of Asian Expert Group, plus on diabetic food, board member of International Wound Practice and Research Association, and also member of Wound Expert Board. He is also adjunct professor, Department of Surgery, Institute of Medical Science, Benares Hindu University of India. So, without wasting much time, I would now request Dr. Hari sir to come and dais, and the stage is yours, sir.
Thank you. A very good afternoon. Yeah. Okay. Okay. Very good afternoon, everyone. Firstly, I would like to thank Lincoln University for organizing the webinar. Now, secondly, I would like to apologize that I have to give you a lecture after food, especially most people are all hyperglycemic now at the moment. So, it's very nice, especially to have a good nap with an aircon now. And I'll be talking about topical oxygen. Now, in the previous lecture, I think Louis has mentioned about diabetic foot during the COVID pandemic and also about using hyperbaric oxygen therapy and all these things. So, we have to be very, very careful about that. Now, in Malaysia, basically, I think hyperbaric oxygen therapy is being used in the Ministry of Defense, hospitals, and also in the private sector. The government sector, unfortunately, at the Ministry of Health, we don't have any topical oxygen, any hyperbaric oxygen therapy. But the thing is, we're actually supposed to actually get one for the wound care unit in Kuala Lumpur Hospital. Now, it's supposed to be there for the past 2 years, donated by Zichi Foundation, but we're still waiting for the grant for renovations to our center to actually put it in. Now, without further ado, I'll start on topical oxygen therapy in clinical wound management. Now, this is Kuala Lumpur Hospital, where I've been working for the past 23 years. And the thing is, this is the Specialist Complex and Laboratory Care Center, where the wound care unit is in the 8th floor here. All right. So 8th floor, 8th of April 2013, basically with 8 staff, 8 a.m. in the morning. And after 8 years of trying before that, we have actually now started increasing our number of patients because 8 is supposed to be fun, right? So a lot of luck. So what has happened basically is we started off with 2,700 patients in 2013. And then in 2019, we had about 14,751 patients. Now, I just got hot from the oven basically now that last year, even though, we had MCO and everything else, our numbers was at about 20,000. So we had 20,000 patients in the world, in the country's largest wound center in 2020 itself. So this year I expect it to increase even though we are having MCO or not, because last year the same thing happened. Now, oxygen was first identified in 1774, the third most abundant element in the universe. It accounts for about 2/3 of the mass of the human body. So it's a highly reactive element and is capable of combining with most other elements. It is required by most living organisms. So you know about aerobic bacteria, and aerobic bacteria basically requires oxygen also. And that's why in cases of anaerobic conditions whereby we have anaerobic bacteria, oxygen can actually help to make it more aerobic. So these organisms cannot start to multiply. Now, the air we breathe in is 21% oxygen. All right. Now, role of oxygen in wound healing. So if you look at this graph at the left side, you can see what you call this, that aerobic metabolism occurs at about 20 meter mercury. So anything below 45 meter mercury, there's impaired healing. All right. Below 20 is non-healing completely, and you have tissue death when you go even lower. So normal healing should be above 45 meter mercury here in subcutaneous PO2 levels. So oxygen in wound healing is more than just a nutrient. Okay, it's from the World Journal of Surgery. So it's very, very important in the sense that wound healing is a very complex cellular and molecular process. We look at hemostasis and tissue repair as mentioned by Westerby in 85. Now, oxygen is required in the case of hemostasis in the inflammatory phase, the proliferative, maturation, and remodeling phases. It's very important in all these phases that we need for wound healing itself. That's why we need to make sure there's sufficient oxygen for wound healing. Now, oxygen availability in normal healing. Although hypoxia acts as the initial stimulant to begin the process of wound healing, chronic hypoxia cannot sustain the process. So we need to make sure that what we call is we have to have sufficient oxygen during the phases of wound healing itself. So if you look at the graph, you can see the blue dotted line basically showing the oxygen levels. So after a while, it still has to go up. You still require oxygen so that what we call is it's important for all the phases of wound healing itself. Now, oxygen in wound healing can actually work as a substrate because why? You find you have ATP production. It can also do respiratory bursts. There can be protein synthesis and also as a signal. That means macrophage VEGF secretion and PDGF receptor increase and cell proliferation increase. Now, this is very important because you want to talk about angiogenesis, you want to talk about what we call the cell proliferation. So all these things require oxygen itself. Okay, and oxygen is critical to many of the processes required in wound healing itself. So the presence of a wound increases the body's need for oxygen. So 20% for a patient with a clean wound. So if you have no infection, basically, if you look at the wound bed preparation and you find the bacterial burden is not there, thereby it's quite clean, then you have 20% the need for oxygen, basically. All right. And 50% for a patient with an infected wound. Because why? When you have infected wound, basically you require more oxygen for energy and also as a what you call signal, basically, all that. So 50% for a patient with an infected wound. Now, oxygen is a key element in many of these processes. Number one, epithelialization. So you want to talk about healing of wounds and all that with full epithelialization, which is supposed to be pink according to the color model by Lars Sjogren's. You basically will talk about epithelialization. Then you talk about angiogenesis. Now, what happens is diabetic foot, you find a lot of cases are actually coming in now with ischemia. And ischemia in the sense that previously, I think when I was a medical student, about 25 years ago plus, we usually what we call is look at ischemia as about 10% and neuropathy about 90%. Now we find that ischemia is more than 40%, and there's neuroischemic foot and all that. So be very, very careful with that. So we need sufficient angiogenesis. Just endovascular work and bypass might not be sufficient for most cases. So the thing is, we need to have what we call proper angiogenesis to help. So what do you call that? You find that a lot of times we end up losing the battle because there is not proper supply of blood. Now, granulation tissue formation is also important. This is characterized as red color in the color model. Collagenesis, basically formation of collagen, and then bacterial killing. Now, bacterial killing basically is in terms, if you look at the principles of best practice from the World Union of Wound Societies, launched in the year 2008, it talks about what they call that infection. And infection can be divided into contamination, colonization, critically colonized, and infection, overt infection. Now, interestingly, the International Institute of Wound Infection, all right, have actually removed critical colonization. Because when do you say it's critically colonized? When do you say it's infection? Very difficult to differentiate. So they've removed that. So the latest principle basically is you look at contamination, you divide the process of contamination, colonization, and infection. All right. Now, the role of oxygen in healing, if you look at this, the rate and quality of blood vessels affected by oxygen levels. All right. Supplemental oxygen accelerate blood vessel growth. As you have seen, basically, what happens is you need the VGF and all that. So this actually, oxygen actually helps in terms of that. Now, metabolism and wound healing, if you look at whole body energy needs increase, 20% for a clean wound, 50% for infected wound. You already seen that. And for healing, local cellular metabolic needs in the wound go up by about 500%. So if you look at what you call this particular this thing where you look at, your PDGFs, your coagulation platelets, inflammation itself, debridement, resistance, and also, all the different kinds of products here with collagen lysis and collagen synthesis and all that, you need at least 500% increase in the local metabolic needs. Low oxygen wound oxygen levels significantly restrict energy production and therefore limits the wound healing itself. So if you look at this, cellular oxygen activity to heal wounds needs energy. This energy production needs oxygen. All right. So when you have in the mitochondria, basically you have the Krebs cycle. So you need oxygen for that. If you have low oxygen levels, you only get 2 energy molecules or 2 adenosine triphosphate. But in normal oxygen levels, you get 36 adenosine triphosphate. So there is 18 times difference basically when you look at when the levels of oxygen is sufficient. Now, oxygen is essential during the neutrophil or macrophage respiratory bursts. So these actually produce reactive oxygen species, okay, which you all know about, which are extremely important in microbial and debris clearance. That means basically what you call that is you need it for clearance of infection or bacterial burden. So during the neutrophil or macrophage respiratory bursts, oxygen demand increases by 50 times. So you need more oxygen for this basically. And this is important basically when you want to clear infection, clear microbial content. All right, because Paul Bowler had actually mentioned in diabetic foot, there's multiple organisms inside, can be anywhere 3 to 9 different organisms, and he called it a polymicrobial soup. All right, so you have multiple types of organisms there. Unfortunately, when we take CNS and all that in hospital to look at culture and sensitivity, or even in the private, when we take biopsies and all that, we only end up with either one organism or two organisms. We don't get all of the organisms. And in quite a number of cases, we actually end up with mixed growth, and we have to repeat the whole thing. So it becomes a bit of a problem now, basically, because we need to know what is the sensitivity of these kinds of bacteria. Now, collagen synthesis is oxygen dependent. So the collagen formed in hypoxic environments is only 30% as strong as collagen formed in normal oxygen concentrations. So if you get a weak, what you call collagen fibers and all these things, you find out that the wound will actually break down again. All right. So the best is what you call is you have to have sufficient oxygen concentrations. Now, epithelial coverage. If you look at epithelial cell migration, is significantly impaired in wounds with low oxygen concentration. Now, we always talk about the periwound area. You talk about like time concept with the S for surrounding skin, triangle wound assessment where you look at the periwound skin area. You have got different classifications for that, everything of that. And we always look at the epithelial cell migration. That means the keratinocytes or the dermocytes or even the epithelial cells. I mean, they don't have many names. They actually come in from the peripheries, from the surrounding skin, and they need oxygen to actually what you call this come into the wound milieu itself. Now, delivering low flow oxygen to a diabetic wound has been shown to increase the rate of wound closure by as much as 69%. Because the thing is, you want to find out when you put oxygen onto a diabetic foot ulcer or a diabetic wound, what do you call that? You find that there's an increase in the rate of wound closure. And 69% is quite a high rate, basically. Now, for diabetic foot ulcers, what you need is you need a 50% closure rate within the first 4 weeks. This is to show that the wound will go and end up closing or end up healing completely within 12 weeks. That is the international standard of care, international standards that we conform. All right. The additional effects of oxygen are such as it has antimicrobial actions, okay, against aerobic bacteria, against anaerobic bacteria with the reactive oxygen species on that. It potentiates antibiotic effects. All right. And this accelerates angiogenesis and is involved in cell signaling. All right. So you need oxygen for all these factors. Now, the impact of wound hypoxia. When you have hypoxia, this is actually the Wounds UK Expert Panel Report 2017. All right, I had the pleasure of actually representing Malaysia in this particular expert panel meeting, whereby we look at the consensus roundtable meeting, where clinical pathway for using topical therapy in practice. All right, so this is held basically in Windsor, London. And if you look at this, basically you find that when you have wound hypoxia on healing, if you have a persistent hypoxia, you find the antimicrobial activity is reduced, the cellular metabolism and proliferation is reduced, and the angiogenesis is reduced. So multiple problems, and you find that the wound bioburden risk of infection increases. All right, and there's reduced collagen synthesis and quality, and reduced expression of growth factors, and reduced extracellular matrix synthesis. So basically, you find that it's reduced cellular proliferation also. So all these compromise healing itself. Now look at tissue oxygen levels. You need to predict wound healing. Now, a systematic review and analysis of tests to predict wound healing in diabetic foot. Now, this is actually done in the year 2016. And you find systematic reviews and analysis like how Lewin has presented earlier in the previous thing. If you look at levels of evidence, especially if you look at SIGN, basically, the Scottish Intercollegiate Guidelines and work, they actually put what they call is meta-analysis and also systematic reviews with low bias as a level 1 evidence. All right. And what do we find actually in this particular thing? We are looking at summarize the evidence on non-invasive screening tests for the prediction of wound healing and the risk of amputation in diabetic foot ulcers. So one of the things that they found basically was TCPO2. Now, Lewin has mentioned about TCPO2, basically when the levels are below 25 milliliter mercury, for you to revascularize, to increase the blood supply again to the foot or to the ulcer itself. Of the 8 tests evaluated, you find that TCPO2 was the best predictor with a diagnostic odds ratio of 15.8. All right. So, in other words, the amount of oxygen present strongly determines whether wound healing will occur. So, you have to have sufficient oxygen, basically. All right. And TCPO levels are important, and you use a transcutaneous oximeter. Okay. Kuala Lumpur Hospital has got a transcutaneous oximeter whereby what you call this, we are able to assess and see whether how is the oxygen concentration. All right. And also your main importantly is your tissue perfusion. All right. So this actually proves that it is an important tool to actually assess for uh, hypoxia. Now, before we go off to China and all that, we come to moist. Now, just now I spoke to you about times. Times is tissue, infection, inflammation, moisture balance, epidermal margin, and finally is surrounding skin. TOWA, which actually was propagated by Caroline Dowsett and Keith Harding in the year 2017, talked about the triangular wound assessment, whereby you look at the wound bed, the wound edge, and the peri-wound skin. All right. And then the third one, which is known as moist. Now, moist basically actually was propagated and supported by the German-speaking countries. All right, by the wound duck. Wound basically, and then is which you have to manage, and duck is DACH, which is Dutch, Austria, and Switzerland. So this is for the German-speaking countries. So they came out with moist. So in moist, what you have is, if you look at TI and M, tissue management, infection control, and moisture balance, is your time again, TIM. And then instead of an E for the H, they've put in here as oxygen balance. Now, oxygen balance basically to see whether you have sufficient oxygen. Now, there are many types of products which can give oxygen. Number one is the one that has got, which is the most famous of all, is hyperbaric oxygen therapy. Now, hyperbaric oxygen therapy, basically HbO2 is famous in quite a number of places, especially quite a number of chambers are found in Taiwan, in the UK, in the US especially, and also in Australia and Europe. And then you have got uh, topical hemoglobin spray, which is your Granulox, which has now been what do you call it, sold by Monlaka, whereby you actually spray in hemoglobin, synthetic hemoglobin, and this hemoglobin will absorb the oxygen. And the pressure gradient between the higher oxygen level and the lower oxygen level, the hypoxic level of the wounds, basically allow the oxygen to uh, move in or to be transferred. Okay, it's absorbed into the wound itself. All right, and then you have got topical continuous oxygen therapy. This is where we talk about natrox therapy, where you don't have to throw away the machine or that. It can last up to a month, 2 months, no problem. You just have to change the oxygen diffusion system. And then you have got the EpiFlow. EpiFlow basically is a disposable one. That means you use it for about 2 weeks and then you throw it away. And then you start another device for another 2 weeks. So this is a full oxygen supply, and after about 2 weeks, it just goes off. That's the end. All right. And then if you look at other forms of oxygen, some people usually use specialized oxygen on different areas and all that. So that's the problem. Now, ozone basically has not been supported in the sense that the Ministry of Health has actually banned usage of ozone treatment for patients and all that. Then the next one is support. Now, as support, the moist here, support basically means negative pressure wound therapy, and also what you call that, other forms of support, basically biological tissue. You can have dermograph, you can have endofoam, you can have integra, quite a lot of things, chorion, amnion. So a lot of things are actually being what you call is propagated by using this. And this is actually a supportive thing. So you can also mention this as adjunctive therapies. So moist, the next one, you're supposed to maintain your sun. So the other thing about moist also is to talk about moist wound healing. George Winter in 62-71 talked about moist wound healing, and this also propagates so you maintain moisture in the wounds. Now, contraindication for topical continuous oxygen therapy is gangrene. If you already have gangrene, there is a block. There is a reduction or a
This
block
doctor
in
is
basically
very
blood
good,
supply.
Dalia. See his face.
All right.
Krishna
So,
Nair, Hari Krishna Nair.
yes. Okay. So what happened basically, if you have a decreased blood supply to the leg and all these things, you cannot send topical oxygen inside because I mean for ischemic, yes, but not complete gangrene. All right. So you need to revascularize the thing. See where the block is basically, whether it is at the femoral level or at the popliteal level, or even at the PTA or the dorsalis pedis level. Now we go straight in topical oxygen itself. This actually is a bridge, basically in Johor, whereby we always talk about connecting two different cities. So this actually is one of the main dictums I use here is bridging the gap. So this is important because you need to bridge the gap. That means you basically use, let's say, particular knowledge or even any acumen, any what you call is expertise or whatever. You need to bridge the gap. That means basically when I mentioned to you, you actually can sit, listen, and basically process the thoughts. Looking at topical continuous oxygen therapy. Now, if you look at topical continuous oxygen therapy, oxygen is produced via catalytic reaction delivered to the wound bed. So it's applied bound to a carrier like fluorocarbons. Okay, so some of the issues is you must look at the stability of the fluorocarbon molecule itself. And some of them actually supply from a reservoir via a delivery system like this, basically, on the right hand side, whereby you can use boots and sleeves and all that. Okay, but this covers over the whole large area, you see. So it's something much, much older compared to what we call is the newer devices, which are more specific. But the only problem with the newer devices like Natrox and all that is the ODS is small. They don't have a bigger ODS. So if you find like a large wound, you have to put at least 2 or 3 ODSs, all right, which is your oxygen diffusion system. Now, your topical continuous oxygen therapy allows direct delivery of oxygen to the wound bed itself. Okay, so standard dressing for wound management can still be used, permits ambulatory therapy. So patient can come in, you can apply what we call this the Natrox device, put the topical continuous oxygen there basically, and then seal off with a semi-permeable membrane. All right, and that allows what we call is the wounds to maintain. Because the thing is, when you put oxygen on a wound, it starts to exudate, starts to form a lot of exudates. It starts to form what we call is a lot of moisture. So this fluid has to be absorbed out. So the best basically is to put a semi-permeable absorbent dressing. Now, as I mentioned earlier, if you compare oxygen therapies of hyperbaric, local perfusion, and Natrox itself, different hours they are actually spent in. All right, hyperbaric is about maybe 4% here basically, where they use daily oxygen therapy is about 1.5 hours to 1 hour basically. And the thing is, if you look at Natrox, it's continuous. So when you look at this, do you want to differentiate between hyperbaric, local perfusion, Natrox, or what? Or maybe you think of coupling it. Okay, basically, number one, patient comes in for hyperbaric treatment in the morning, where you put a hyperbaric patient in hyperbaric for pressurized at least 2 ATA, 2.4 ATA, depending on the conditions. It'll go up to about maybe what do you call this? I mean, you can go all the way up to about 3 ATA. And the thing is, usually when you put hyperbaric itself, it'll be an hour, another half hours, 1.5 hours every day. All right. So you do Monday to Friday, and then after you continue on there, you do about 30 sessions. Now the thing is, why not just for food for thought, basically, you put the hyperbaric on, and then you apply a Natrox topical device, all right, or an EpiFlow, up to you, whichever one is there, at least topical continuous oxygen, you apply it into the wound itself. Now that actually helps in terms of increasing the blood supply, plus also helping in terms of wound management itself. All right. So you might want to couple both, especially when you have more difficult cases on that. All right. But mind you, basically, when you put topical continuous oxygen therapy, debride first before you apply. All right. Don't just put on. And one of the most important dictums is you are doctors and you are nurses and all that, and you are paramedics and all that. So what happens is you have to develop your experience with the different kinds of products. All right. The salespeople will tell you everything is great, everything is wonderful. All right, and all works well and all that. So until you try out the thing, that's why we had the wound expert board meeting, whereby we will discuss about this in Windsor in London there, because the thing is everyone says everything is good, all right, which cannot be the case, you see, and you cannot say that without proper evidence. So evidence-based medicine is very important. Now, what wounds is it suitable for? It's suitable for hypoxic wounds. That means there must be decrease in oxygen. Now, in diabetes, basically in diabetic mellitus and all that, you find that 20% of the Malaysian population above the age of 18 have got diabetes, or 17.5% from birth, which is from the National Health Mobility Study, on the third one. And then you have got what you call that another this thing whereby you find that every 20 seconds a foot is being amputated. Every 7 seconds a diabetic patient dies. Okay, so that is a big problem nowadays. And you find in diabetes itself, you can have neuroischemia. So you can have hypoxia also, in particular in the diabetic foot ulcers. And then you have got also venous disease. In venous disease, because of the perfusion, reperfusion, injuries and all that, you also have tissue hypoxia, and also in pressure injury. So you can use what we call this, the topical continuous oxygen therapy. Now, low wound oxygen is actually shown here. That's failure to fight the infection, poor quality of tissue repair, and inability to produce new cells. So this is cases where you actually can put the topical continuous oxygen therapy, but debride the whole wound first, remove all the sloughy areas, dead tissue, devitalized tissue, everything, all that, and then only you put your topical continuous oxygen therapy. Now this actually is in Chiang Mai, basically what you call this in Thailand. I just give you a visit of a few of the countries during the like an ASEAN trip kind of thing. Anyway, just for your information, we have the ASEAN Wound Council, which has got 10 countries inside, and what do you call this? This council is actually founded and chaired by me, and it was actually founded in 2018 in Kuching, Sarawak, when we actually signed the Kuching Declaration. Now, some of the evidence for topical continuous oxygen therapy. Now, this is the consensus roundtable meeting, topical oxygen therapy for healing of complex wounds. All right. So this was actually held basically in the UK. And then we have got a Wounds Disease Journal, which also has got about 2 papers on topical oxygen therapy. Like this, basically evaluating the outcomes of 8 patients topical with diabetic foot ulcers using a new topical oxygen delivery device. Now, this is actually a Scopus Index journal. So you look at products, and this one you can see many cases, especially what you call is you can have venous ulcers, you can have diabetic foot ulcers, you can even have what you call this those what chronic venous insufficiency, basically causing all these problems. All right, and you can see the duration of therapy here, basically how long we used it. And then we have one more basically where we looked at Tan Tock Seng, what do you call this, hospital? Sorry, Singapore GH, Singapore General Hospital, and also what do you call this, HKR. All right. So we actually put, you can see here, we actually put the oxygen diffusion device onto the particular foot which has been amputated here, and then use the what do you call this dressing. That means cover up what do you call this with foam. Here, same thing for diabetic foot ulcers. All right. So this actually shows how topical oxygen flow can actually help complex wounds. Then we had a portable, practical, and effective clinical benefits of Natrox topical oxygen therapy paper. Now, this is actually submitted to Journal of Wound Care, which has got an impact factor of 1.9, and it's also Scopus Index. And you can see basically what you call this is by Finn Gottrup and group with Eunice, John Lantis, and we've also got a list of case studies on different countries. All right. Now, the evidence for translational oxygen, it can be one more case is basically with a prospective randomized clinical study evaluating the effect of transdermal continuous oxygen therapy on biological processes and foot ulcer healing in persons with diabetes mellitus by Vicky Driver. All right, it actually was published in 2013, where DFUs randomized to topical continuous oxygen therapy and standard wound care. You find the 87% versus 46% reduction in the wound size, and there's a decreased CD68 plus macrophage and count. All right. This macrophage count is reduced, and decreased levels of interleukin 6, 8, and MMP 1, 2, and 9. All right. So what we do now, basically, we have got a small kit which will check the interleukin levels when they get back home. Now, what they find basically is highly significant reduction in wound area. This actually is by Dr. Karen Cross. All right. You can look at the wound area progression, the control, and with Natrox, and P is less than 0.005, which shows what you call that it is significant. So in this particular case, you find that there's 90% of the wounds heal completely with continuous oxygen therapy, compared to only 30% in the control group. All right. This is the Natrox group, and this is the control group. Okay. And then if you look at topical oxygen therapy for diabetic foot ulcers 1 and 2, we did a pilot study basically in Cambridge and London. This is Paul Hayes and group. So this new study funded by the UK NHS, 140 patient blinded, RCT, 42 patients basically registry. So ulcers were greater than about 6 months. So no lower limit on ischemia, no restriction on acid types, and many centers first experience with the device. So 42 patient data available, median age 64. So ulcer size mean about 4.1 to 2.0 median. And then you can see duration 17 months to 12 months. 38% are current smokers. That's the thing. We haven't stopped those people who are smoking. And 72% hypertension, 60% hyperemia, 28% CAD, and 40% adrenal impairment. So 16 patients produce minor or major amputation. All right. And 6% of them are still using some form of offloading. So who do the testing? We cover on podiatry. Malaysia doesn't have podiatry, but basically also done in UK. So you have podiatrists, community nurses, and patients themselves. Patient satisfaction was more than 90%. Okay, that's quite something good, because the reason is because why, when you're putting what you call this topical people can still open it up, and so you would have to make sure that what you call that the wound, the dressing stays inside too. There's significant reduction in wound area across the study. If you look at what you call that, the median here, it has actually reduced, okay, over the weeks of treatment, okay. And then in terms of wound closure also, it has increased. The percentage has gone up basically. All right, and your P is equal to 0.023. Okay, it's still below 0.005, which is still very significant. And then if you look at these slides, basically, you can see 80% of the wound shows, 80% or more shows wound closure. Okay, so average chances to wound area also. Okay. Now, these are the clinical endorsements. Topical therapy for chronic wounds, a report basically. You find that there is one more clinical studies. Got another one. We're looking at what you call topical oxygen. You can see abstracts and everything out there. So these are all the clinical endorsements of this particular product. All right, case series and concepts on that. But the thing is, most people are still not convinced. It's actually a controversial kind of therapy because in diabetic foot ulcers, you find that oxygen basically takes. I mean, it's supposed to be important, but the thing is, they're not too sure how important. There aren't sufficient RCTs to show that it's really what do you call this? You must put in your standard of care. All right, but quite a number of studies, basically case series, what do you call it, expert opinions, everything have been given on this particular device. Now, if you look at evidence for topical therapy, basically what do you call this? You got another list here. All right, for those people with severe diabetic foot ulcers, you have prospective randomized clinical study. You've got topical therapy reduces Oscar and other factors and improves closure of clinical presented wounds. So quite a number of studies, basically, which shows, and these things are all submitted into ostomy and also in clinical and experimental pharmacology. Now, Hannah Kaufman, just to show you here, is from Israel, and she has about more than 200 cases. All right, so she published quite extensively on the topical corticosteroid therapy. So she's actually an orthopedic surgeon in Jerusalem, and she finds what they call it. A lot of patients actually heal well when she just uses her topical continuous oxygen therapy. Okay, Hayes here basically looked at cases of diabetic foot ulcers. All right, so wherever he looked at cases which has got a little bit of ischemia. Kiran, same thing. Case series of patients with critically ischemia and chronic ulcers. Mani basically talked about observational study in patients with VIUs. So the thing is, he wrote it in the Journal of Wound Technology, and the wound area reduced by a mean of 58% over the 6-week study period. So no adverse events were noted. Pain scores decrease in all patients. Now this is Angkor Wat in Cambodia. All right. Now next we go to clinical application. This is the oxygen generator basically on your left, and then you have got the rechargeable batteries here, where you actually fix it inside here, so you must charge these batteries. Now this device basically, please don't throw it away, it can still be used. The oxygen delivery system is the one that can be removed and changed. All right, so the oxygen delivery system basically ODS, every single session when we do dressings, we have to remove this. Okay. Now, if you look at the simple application, basically you clean the wound, all that, you apply what you call it continuous oxygen therapy, you cover up with the dressing, all right, and then you fix it up there. Usually what you do is you use the nitrox divide to fix it over in the thigh or even in the patient itself in the house. Right. And then the thing is, after you put the ODS on top, what you do is close it up with a cerebral membrane. All right, you can see here, this is how it looks like, and then you plug it into the generator, and nitrox will shoot the oxygen down, all right, into the ODS here. Okay. All right. Now here you can see charging the battery itself. Now what happens is before we charge the battery, I mean, what you do is there's a string is, I mean, the tube is quite long. So some people, they put it as a pouch or in the pouch basically at the thigh, or they put it in their pocket. All right. Charging basically is important when you charge the battery. All right. Now, what actually happens after putting on the nitrogen oxygen wound therapy or the topical continuous oxygen therapy? The first 1 to 2 weeks, there's an increase in X-ray. There's an increase in wound size, as measured by length and width. All right, and there's decrease in pain. All right, so this is for the first 2 weeks. So what do you do when you too much X-ray? Try to apply what you call is some barrier creams and all that, or even barrier sprays, barrier lotions and all that to prevent maceration. Number 2, what you call this is apply a proper semi-absorbent, semi-permeable foam dressing, which can absorb as much as you can. All right. By week 3 and 4, the X-ray comes down, the wound reaches original size and improve wound bed and color. Now in week 5, basically, there's a decrease in wound size, granulation tissue, and reappraisation is actually evident. Okay. So on average, therapy will need to be maintained for 8 to 12 weeks to achieve complete healing. Yes, just show you some of the cases. Now in this particular patient, day 1 to day 31, All right, there's a diabetic foot ulcer. You can see the wound improving. The interesting part is within 31 days. The normal thing of a wound improving completely vertically with no other problems is about 16 days. So when in this particular thing, when you use topical corticosteroid therapy, after 31 days, the wound is completely closed. Right. In this case, it took about 41 days. Another case of diabetic foot ulcer. All right. So day one was being infected a bit. So they just waited for the infection to clear. And finally, what you call is on day 41, basically, after day 34, day 41. Day 41, you can see the wound is completely clean. All right. And healed. Okay. So it's healed within 41 days. Now, this is also to show on a venous leg ulcer. We're talking about chronic wounds, not only diabetic foot ulcers, but venous leg ulcers. Now, venous leg ulcers, as I mentioned to you, also can have hypoxia. Now, one of the important things in this thing is when you actually apply the topical corticosteroid therapy, you can also put compression. All right. Now, the thing is whether you're going to put 4-layer compression or 2-layer compression, depending. So, most of us try to put 2-layer compression on top of the ODS device, so it's not too tight. 4-layer can be a bit more tight, compression will be a bit more higher, basically. So, after that, what you call is you keep it on and you can see the difference. About only 4 days, the wound starts to close or the wound is healed. The thing is, in venous leg ulcers takes longer. It is not what you call this 3 months or whatever, or even up to 6 months, according to diabetic foot ulcers. And you find venous leg ulcers within the first 4 weeks, there should be 20% closure or 20% reduction in wound area itself. All right. So we use it for the venous leg ulcer. And then another patient, diabetic foot ulcer, took about 49 days. You can see basically on the side, basically how the wound is actually red and it starts to improve. Okay, final epithelialization basically on day 78. Now this is another patient, a male, 56 years old, diabetic foot ulcer also, who came in, and this took a bit longer because the patient was ambulating and he's at the joint level and all these things. So whatever swelling the patient has on top will come to the joint itself. All right, and you can see the difference. The wound has improved much nicely. Okay. And then you have got another 73-year-old patient who's got a diabetic foot ulcer. Now, interestingly, we first thought what we call that it was maybe a venous ulcer or what, but I think it is a bit more lower, and you find that it doesn't have the normal symptoms. And the inside of this place was actually infected. He actually also had bone osteomyelitis. All right, but the thing is that was by chest X-ray and by X-ray of the foot, and also with what do you call this, your laser checking through. And we find that the 70-year-old DFU actually start to heal. Okay, so you must differentiate. If the patient is diabetic, doesn't mean he has a diabetic foot ulcer. But most of the time, he'll have a diabetic foot ulcer itself. But a patient who's got a venous ulcer can be a venous ulcer patient with diabetes itself. So it's important for you to actually categorize this. Now, with that, what you call this, I would like to just state that your topical corticosteroid therapy, if you look comparatively to other forms, can be depending on the pricing itself. Okay, and the thing is, some people basically put just let's say Natrox device or whatever onto the wound without anything else. Now you can couple other kinds of dressings with the particular device itself. All right, that'll be quite helpful. Okay. And the thing is, at the end of the day, if you look at this, is a picture of Geneva, and every building here, basically, when you look at it, is supposed to be a brand of a watch. That means Raymond Weil, Philippe Patek, basically Alfred Dunhill. So all of it is one basically. So you have one side here basically nutrients and all that. You have got what you call is research. You have got uh, topical conversion therapy. There is also laser therapy. There's a lot of other therapies, adjunctive therapies. And as Louis has mentioned earlier, basically adjunctive therapies can help us to actually heal the wounds faster. It's an additional therapy to whatever we're doing. That means you still have to basically assess the wounds, cleanse it, debride it, deslove it, and then what you call this, force it or whatever, and take the whole wound into a better paradigm. Now, I'm sorry, in the afternoon, everybody is hypoglycemic. So with that, I would like to, what do you call this, thank you for your kind attention, and open to any questions.
Thank you, sir. Participant, please, any question?
I think to ask one particular thing is ozone therapy, is it beneficial? There's one from here. Now, ozone therapy basically has been actually banned in Malaysia by the Ministry of Health. The Deputy Director of Health before this has actually banned ozone itself because it's very specific. And thing is, there's not much of evidence-based medicine. Most of the evidence basically is more of level 4. I mean, case series or case studies or what, which, and a lot of it has not been published. So we don't advocate using ozone itself. But topical corticosteroid is actually picking up. Yeah, especially in cases of where in cases where you look at Cambridge, where Paul Hayes did a study, he actually looked at ischemic foot. All right. And ischemic foot, please take in mind that the ABPI or the ABSI should be below 0.8, but it should not be below 0.5. Below 0.5 will be critical limb ischemia, whereby you need to go for endovascular or even a bypass. That means you have to revascularize the foot. All right. And the revascularization is very important. And the thing is, they have come out with what they call as a concept about a few years ago, looking at angiosomal approach, whereby you have a blood supply coming in from the artery, goes out to the vein. That whole area is in a three-dimensional block, and the blood supply is according to that. So do not cut or amputate across the angiosome, because then you'll have a problem with that. Another thing is, I think another question here is, along with topical oxygen therapy, are other secondary dressings applied like hydrogels or hydrofiber dressing to the wound? Okay, what you can do is, for when you put topical oxygen therapy, I like to apply things like collagen. There's simple collagens in between the ODS itself, because oxygen actually will potentiate this. You can use a bit of hydrogel also, especially if you got a bone exposed or tendon exposed. The other thing is hydrofiber. I think you shouldn't use that. You're already using foam, okay? Unless you want to use Aquacell foam, which is hydrofiber foam, can also, but it'll increase the price to that. All right. And what is the criteria for candidate for oxygen therapy? Basically, any particular wound which is number one should be clean, relatively clean. You might have what we call is a bit of colonization or a bit of contamination, but it shouldn't be infected. If let's say infected, or if let's say there's a necrotic patch or even dead tissue or devitalized tissue or anything, debride the whole thing. Most important dictum: do not put the oxygen on top of that. You just form like a chicken chop kind of layer. So you need to debride. After debridement, you can put it on. And the pricing for the topical therapy now, basically, I think in hospitals, what happens is we actually buy by the ODS itself, the oxygen diffusion device. Now, the oxygen diffusion device basically is about 180 ringgit. So you have to change that every few days and all that. And the thing is, if you usually if you buy about 30 ODS, they will give you the device for free. All right, and then you can continue. And the device is not disposable, because you must know there's two types of devices: Epiflow and Natrox. Epiflow is active in Singapore. In Malaysia, it's not so much, because the price of the Epiflow is quite expensive. All right, it's about 1,500 Sing dollars for 2 weeks, and if you need to put it on for 6 weeks, it's going to cost about 4,500, which is going to be about close to 13,000 over ringgit just for the Epiflow itself, and it's disposable. After you finish using Epiflow, you throw it away. It comes from Ogenics from the US. While Natrox, basically, you can reuse again. So the generator is there, the battery is rechargeable. The only problem basically that we have is the ODS for the Natrox is very small. Okay, so you only can use for a small wound, anywhere up to about 10 by 10 cm, yes. But if you have a huge wound, 20 by 10 or even 30 by 10 or anything more than 100 centimeters square, you find that you have to put multiple ODS devices. All right, they have assured us they're trying to get a bigger ODS, but at the moment they haven't, because some of the problems is to maintain the pressure along the whole way to get 100% oxygen all the way through the oxygen diffusion device itself. Now the other one is, can topical oxygen be applicable for cancerous wounds? Okay, when it comes to malignancies or even for tumors and all that, you have to be a bit careful, because you have got malignant cells which are actually replicating very fast. And interestingly, malignant cells also need oxygen. So when you end up putting topical continuous oxygen on top of that, you're also going to speed up the tumor. So that's one thing. And then the thing is, it'll be also, one more thing is, in the first 2 weeks, it'll be very, very exudative. All right, so it gets wet, it gets macerated, especially in fungating tumors. However, if you have removed the tumor itself, completely excised it, basically if it's a level 1, if it is a stage 1, stage 2, or even let's say stage 3 or stage 4, when you're doing more palliative care or whatever, you can apply the oxygen on top of that. All right. And the thing is, that is some of the things that are very important if you look at. And the other thing also is, if you look at tumors, they're also very friable. And then you find that some of the blood supply might be also exposed. So they can bleed also. So you have to be careful with that. All right. Now, how do I want to do topical oxygen therapy in district hospital? Now, the good thing about the topical oxygen therapy is it is mobile. That means you can use it in the hospital, you can use it in the health clinic, and you can also do it at home. Okay, so in the government practice, basically like in Kuala Lumpur Hospital, the wound center, we buy the ODS and we use it. So patients get it for free. All right. In the health clinics and all that, you can also purchase under a local purchase order, or you can actually ask the patients to buy. All right, you can contact the salespeople or whatever, and you can get them to buy also. And this device is also taken back home. We don't only use it when patients are actually admitted. We also use it at home. All right, so you can use it under home nursing. You can use it from clinics and primary care centers where the patient can go back with that. All right, so there shouldn't be any problem with this. Only thing is choose the patient carefully. The choice of these patients is important because the thing is you choose them according to the hypoxia itself. Do not put topical anesthesia in a case where there is gangrene. All right, above the gangrene, whereby you find that there is still some problem or there's still some ischemia, and at the same time in patients you have done basically you have revascularized the wound and all that. Yes, you can apply. All right. Otherwise, not in a fully ischemic foot, especially if they have got critical limb ischemia. Because the thing is, it will take a long time and there'll be a lot of problems. For ischemic foot, just plain ischemic foot, basically, I mean, Paul Hayes has actually shown in Cambridge that it actually works. All right. Okay. Any more questions?
Sir, I have one.
Mhm.
If what about the oxygen therapy on eczema? Local oxygen therapy can be done.
Okay. The thing is with eczema, if it's going to be just what you call is atopic eczema, or even what you call is allergy dermatitis or contact dermatitis or any of these things, smaller areas, yes, but large area is going to be a problem. All right, so you can't actually apply the oxygen on large areas. And then the other thing basically is patient has also got a lot of what do you call this itchiness and all these things, and you find that the area is not actually hypoxic; it's actually exposed to the air. And the thing is, there is no decrease in oxygen supply. So by using the topical oxygen, it will not give you that much a benefit. Number one. Number two, when you use it also, you find it becomes very exudative if I even macerate this thing there. So for eczema, it'll be better actually to see the dermatologist and use normally what you call is the steroid applications, the collagens, the our protopic ointments and those things. I think those work better in comparison. There's also a question here on does body temperature variation, body heat help? Okay, one of the dictums of basically wound management is try to maintain it as close to normal as you can in any form. So basically, even body temperature should be 36.9, anywhere around. Do not go more than 0.5 above. All right. So that's why what you call is when we actually apply some of the dressings, we always make sure what you call is the dressings are at either room temperature and all that, or even body temperature is the best. Because if you go and chill it basically in the freezer and all these things, and you put it onto the wound, what will happen is there's a vasoconstriction of the vessels and all that. All right. And the thing is, and then there's one group which knows that, and there's another group of patients who find that they learned in Form 5 science, basically when you have heat over an area, you vasodilate the vessels. And then what they do is by using that minimal knowledge, they actually put the whole leg, especially diabetic patients, into the hot water. They don't actually assess with their elbow because you've got glove and sucking distribution, you've got peripheral neuropathy. So diabetic peripheral neuropathy is a big problem. So you shouldn't basically put into hot water or anything. So you have to be careful and check with your elbow itself. Yes, correct. So you don't use what you call is your finger or even your toes because you cannot actually assess the heat. And the same thing goes when you actually bring the patients to hot springs and all that. Also becomes a problem there. And then just to address one more, I think someone asked about maggot debridement therapy. Now, maggot debridement therapy, we have been using it in Malaysia for 17 years. I'm also reviewing a lot of articles on maggot therapy now. Quite a number of countries are using it. Lucilia cuprina is the type that we're using in Malaysia compared to Lucilia sericata in Europe and also in the US. Australia is not using any maggot therapy at the moment, but Gillian there and also what do you call this, Frank Stadler are actually doing some work with maggots from Australia, but the thing is they're actually managing the cases in Africa. So they don't have any production over in Australia itself. So maggots are quite good in terms of debridement. All right. So if you find, let's say, a wound, you see a wound which is a diabetic foot ulcer, which has got dead tissue, devitalized tissue, got slough and all these things, you can use the maggots to debride. All right. And after the maggots finish their work, basically, and the debridement is completely done, only then you can end up using the topical continuous oxygen therapy. All right. It's an additional thing to that. right? Okay. Any other questions? Any other questions? We still have 9 minutes.
Yes, Dr. Maniam asked, honey and ghee, does it promote baking?
Okay. Basically, what you call this, all right, maybe I'll just cover. I think honey, yes, because the thing is, honey has been proven, and you find this is medical grade honey, which has been sterilized, not pasteurized. Now, the honey, medical grade honey basically comes in form of gel, paste, stool, honey colloids, and also in honey with alginate. And the thing is, honey actually helps in terms of debridement, in terms of stimulating wound healing, cuts down the smell, antimicrobial, and also for granulation. All right, it's a 5-pronged this thing for the method of for the mode of effect of honey itself. So it actually is quite effective, and we use quite a number of honeys in the HKL. Now in Malaysia, we have quite a lot of honeys. We have got the Avansis honey, which is LG1 AT1. We have got the Medi honey, and we have got the what do you call it, Mesitran honey, which is a tool dressing also. So you can choose it according to the indications and all that. Now, if I'm not, if I'm reading it correctly, I think ghee basically, usually we use it for food. We have not put ghee on the feet so far. The only thing people have put, as some people have used French oil basically as a moisturizer, not for wounds, but just as a moisturizer per se. So, and the thing is, in Indonesia, there's also some people who put coffee onto the wound. But all of these have got no proper scientific basis per se. I mean, they were not actually what do you call that, published in sound journals with Scopus Index and all that. So we don't use all those things. I know cases where people actually have a burn injury or a thermal injury, they actually end up putting what do you call this, Colgate. They putting what do you call tobacco. They put coffee and all kind of things. All right. So when you come to us, the problem basically is when we're actually cleaning up the wound. It becomes quite painful for the patient itself because multiple things are actually stuck there, and it becomes a bit of a problem. And there is pain when you're removing it, but you have no choice. You have to remove that. But honey shouldn't be a problem. And then the other thing about honey is, if you look at Manuka honey, which is coming from New Zealand, it's actually being used in most of the products coming from the US and also from the UK and all that. Now, in the Mesitran honey is actually a floral honey. All right. So floral honey also is effective. Now, and the thing is, if you know Peter Molan actually came out with UMF, unique Manuka factor. So according to him, he has actually patented that. So those companies which are related to him will have that UMF factor, which will be 12 plus, all right, to show that it's actually efficacious for wound healing itself. All right. Please do not use the honey that is gotten straight from the tree. The person who comes beside the car and says, or even in a restaurant and all that, and says, please use this honey. Now that honey has got bacteria inside, has got fungal spores inside, all kind of things. It has not been sterilized. So you're going to introduce infection, and basically the patient might end up with a BKA or a AKA. All right. So the other honey in stores, basically the commercial grade honey, which are pasteurized also, you have to check, because honey basically is hyper viscous, hypertonic, and all these things. So if you don't sterilize it properly, just use pasteurized honey, it's more for drinking and all that. However, saying that, you find that there are pure honey, such as Tualang honey from Malaysia, and you also have Manuka honey. Okay, and Manuka is a bit expensive, so you can use those kind of honey. But why go for those kinds of commercial honeys which you're not sure about 100% whether how's the efficacy, when you have medical grade honey which you can use? All right, and it's available in Malaysia. Okay. All right, any more burning questions?
I think no more questions, sir.
Yeah. All right,
So
so I'd like to thank you all basically and pass it back to Dr. Sandeep.
thank you, sir.
Thank you very much.
I think Dr. Kelly is already online. So you want to take 5-minute break, or we can start now? Participant?
I'm happy either way, unless the audience would like to have a 5-minute tea break.
Yeah, 5 minutes break,
refreshment.
Andia. What Andia? Next speaker.
Yes. Yes.
She's online, I think.
Yeah. So break for 5 minutes, sir. Madam.
Sure,
5-minute break. Okay.
sure.